Hello and welcome to GastroVision. I am Dr. Qazi Suhail from Government Medical College Srinagar. Today, we are going to talk about something very important. What is new in the 2025 APASL guidelines on acute variceal bleeding? If you are a gastroenterologist, hepatologist, or a trainee preparing for exams, this update is a must know because it represents a big leap forward from the older 2011 guidelines. Acute variceal bleeding, or AVB, remains one of the most feared complications in cirrhosis, with high morbidity and mortality. The APASL 2025 guidelines bring in refined definitions, better risk stratification tools, and more tailored therapies specifically designed for the Asia Pacific region. So let's break down point by point. Earlier, we had broad definitions of acute variceal bleed and rebleeding. Now, APASL introduces the home to door concept, meaning management starts right from the patient's home and continues during transfer and emergency room arrival. They have also included validated risk models like APASL bleed severity score, HVPG guided assessment to predict high risk bleeds, and even artificial intelligence assisted prognostication. This allows us to individualize therapy rather than treating every patient the same way. Traditionally, balloon tamponade and tips were considered lost resort measures, but the 2025 update redefines escalation strategies. The new tools include self-expandable metal stents, SEMS for rapid acute variceal bleed control, early tips, especially if HVPG is greater than 20 mmHg, EUS guided glue and thrombin injection for gastric varices, providing safer alternatives. And in patients with gastrorenal shunts, procedures like BRTO, CARTO, and PARTO are highlighted as frontline options. This means the toolbox for rescue therapy is now much broader. Another key shift, that is antibiotics are no longer one size fits all. Earlier, ceftriaxone was the default choice. Now the guidelines emphasize region-specific antibiotics depending on resistance patterns. Similarly, vasoactive drugs like terlipressin, octreotide, and somatostatin are recommended based on timing, severity, and comorbidities. This personalizes therapy and avoids overuse. Endoscopic variceal ligation still remains the gold standard, but the guidelines now focus on something often neglected, that is, anesthesia protocols and periprocedural risk assessment. This is extremely important because cirrhotic patients carry higher anesthetic risks, and standardized protocols ensure safer endoscopy and better outcomes. These guidelines are not just theoretical, they are practical roadmaps helping physicians and multidisciplinary teams to decide how to stratify patients, when to intervene, and how to optimize limited resources. Another major contribution is standardized definitions for trials and meta analysis, especially. With uniform endpoints, research becomes comparable, allowing stronger evidence to build in the future. Now, let's begin with the definitions. Acute variceal bleeding is defined as hematemesis within 24 hours of presentation, or ongoing melena where the last melanic stool has occurred within the last 24 hours, in a patient with known or suspected portal hypertension. So, in simple words, if a cirrhotic patient vomits blood or passes fresh dark stools within the last 24 hours, that counts as acute variceal bleeding. And importantly, an acute variceal bleed episode is considered to last for 48 hours from the first bleed. Any rebleeding in that period is a part of same episode. How do we know if the patient is actively bleeding at the time of evaluation? APASL defines active bleeding as seeing spurting or oozing from a varix during endoscopy, fresh blood in the nasogastric tube, or hematemesis of fresh blood. This helps us categorize whether the patient needs urgent hemostatic measures. Now, two very important concepts: what is control and what is failure. Control of acute variceal bleed means bleeding has stopped, hemodynamics are stable for at least 24 hours after therapy, and in case of endoscopy, no further bleeding at the end of procedure. Failure to control acute variceal bleed is defined by fresh hematemesis despite correct combination therapy, that is vasoactive plus endoscopic therapy, hemoglobin drop greater than or equal 2 grams per deciliter, or 6% drop in hematocrit without transfusion, or unfortunately patient death. The guidelines also redefine rebleeding into three categories. One is very early, that is within 48 to 120 hours of T0. T0 is first bleeding episode. Early, that is 6 to 42 days from T0, and late, that is after 42 days. Clinically significant rebleeding is when hemoglobin drops greater than or equal 2 grams per deciliter, or when the adjusted blood requirement index is greater than or equal to 0.5. The index bleed is simply the first ever episode of upper GI bleeding in that patient. But outcomes are now measured comprehensively. They don't just stop at bleeding controlled or not. The updated outcomes include control of acute variceal bleed, failure to control bleed, rebleeding, mortality within 42 days, ICU and hospital stay duration, quality of life, development of new decompensations, AKI, hepatic encephalopathy, ischemic hepatitis, delta MELD score at 42 days, and the need for rescue therapies like TIPS or POTO. Two new concepts are highlighted. One is T0. T0 is the exact time when the first bleed occurred, the anchor for all definitions. Home to door time, the time from first symptom onset to hospital arrival. Ideally, it should be 2 hours, but up to 4 hours may be acceptable in less severe cases. This reflects a public health angle, not just what happens in the hospital, but how far the patient reaches definitive care. When to suspect variceal bleeding? Let's say you have a patient presenting with upper GI bleeding. How do you know whether it is variceal or non-variceal? The guidelines give us a checklist on the basis of history. From history, look for hepatitis B or C, alcohol abuse, fatty liver disease, exposure to hepatotoxic substances, or long-term hepatotoxic medications. In physical examination, look for jaundice, ascites, hepatic encephalopathy, splenomegaly, firm hepatomegaly, abdominal wall collaterals or features of liver failure. In imaging, look for signs like spontaneous portosystemic shunts, dilated gastric veins, recanalized umbilical vein, nodular liver, segmental dysmorphia, or periportal space enlargement. In the labs, look for thrombocytopenia, elevated INR, low albumin, high bilirubin, all reflecting synthetic dysfunction. In endoscopy, of course, visualizing varices directly is the most convincing. So, if a patient with upper GI bleed also has these liver-related clues, you should strongly suspect variceal bleeding. The guidelines make it clear the gold standard for diagnosing acute variceal bleeding is upper GI endoscopy. Endoscopy doesn't just diagnose, it also guides therapy immediately. So, it's both diagnostic and therapeutic. Now, how do we diagnose during endoscopy? For esophageal varices, direct spurting or oozing of blood from a varix, signs of recent bleed like the white nipple sign or an overlying clot, presence of red veil markings on varices with blood in the stomach with no other source is found. Even if no blood is in stomach, esophageal varices with red signs plus clinical upper GI bleed can still indicate acute variceal bleed. For gastric varices, same principle, spurting or oozing seen directly, signs of recent bleed like clot or nipple sign, gastric varices with red signs plus blood in stomach in absence of another cause. And remember, the guidelines recommend using Serene's classification to describe the exact site of gastric variceal bleeding. Diagnosis doesn't end with yes or no. We also need to assess how severe the bleed is. The guidelines suggest looking at vital signs, blood pressure and heart rate changes, hemoglobin and hematocrit levels, transfusion requirement, and most importantly, the adjusted blood requirement index or ABRI. These parameters tell us not only whether bleeding is controlled, but also how aggressive it is. Finally, the guidelines emphasize the importance of predictors of severe bleeding and rebleeding. The tool recommended is APASL Bleed Severity Score, a simple, reliable way to stratify patients right at presentation. This allows us to decide which patients need urgent endoscopy, which may require early tips, and how intensively we should monitor them. The guidelines start with the basics: airway, breathing, circulation. Now, first is airway protection. Elective intubation is recommended in specific situations like massive hematemesis, altered mental status, gastric varices, oxygen saturation less than 90%, or massive ascites. Now, another is breathing and circulation. Patients must be on continuous monitoring, ideally with a cardiac monitor. Now, the tricky part: fluids and blood. The guidelines emphasize conservative resuscitation. Why? Because overtransfusion or overhydration can raise portal pressures and increase rebleeding risk. Use of crystalloids like normal saline is recommended. Avoid colloids like albumin. Maintenance fluids like dextrose can be given. Our target should be systolic blood pressure should be 90 to 100 mmHg, heart rate less than 100, CVP 1 to 5 mmHg, urine output 40 ml per hour. In blood transfusion, the goal should be 7 to 8 grams per deciliter, and packed RBCs are preferred. The fresh frozen plasma and platelets, they should be used very cautiously because they can worsen rebleeding. Correcting coagulopathy is still evolving area. In the pharmacological therapy, drugs should be started early, ideally within 30 minutes of the first bleed. In the drugs, we have vasoactive drugs like terlipressin, somatostatin, or octreotide, depending on availability and patient comorbidity. Terlipressin infusion is preferred, that is 4 to 6 mg per 24 hours instead of boluses. Do a baseline ECG if you plan to use terlipressin. After successful endoscopy, stop vasoactive drugs in 24 to 48 hours and switch to non-selective beta blockers if not contraindicated. Tranexamic acid may reduce post-AVL rebleeding. Now, coming to antibiotics. All cirrhotic patients with acute variceal bleed should receive broad-spectrum antibiotics, typically ceftriaxone, for 5 days. Duration may be reduced to 2 days if bleeding is controlled with endoscopy, but exception is child-pug A. These patients may not derive much benefit. Proton pump inhibitors are only used if you suspect non-variceal bleed, and recombinant factor 7A. It is not recommended routinely. Coming to another section, that is ICU care and monitoring. All patients with active acute variceal bleed should be managed in the ICU. The monitoring include cardiac monitoring, IVC monitoring in high-risk groups like elderly, cardiovascular comorbidities, severe or ongoing bleed, shock or renal impairment. Nasoenteric tube can be considered if there is a strong indication like hepatic encephalopathy, but should be used with caution. Endoscopy is essential. All patients with acute upper GI bleed should undergo endoscopy. not just for diagnosis, but with the clear intention to provide endoscopic therapy. Combination therapy is king. The first line treatment is a combination of vasoactive drug plus endoscopic therapy. Ideally, endoscopy should be performed within 6 hours of admission after resuscitation. If not possible, definitely within 12 hours and at latest 24 hours once the patient is stable. Where to perform endoscopy? The best place is endoscopy room. But if the patient is unstable or needs airway protection, bedside endoscopy in the ICU can be done. Who should do endoscopy? Fellows can do band ligation under supervision. Glue injection for gastric varices is done only by an attending or a well-trained fellow. Patients in shock, intubated or ICU bedside must be handled by a consultant. In the pre-endoscopy preparation, blood pressure must be greater than 70 mmHg. Unconscious patients should be intubated before endoscopy. Routine intubation or nasogastric tube placement should be avoided. Intubate only if the patient is actively bleeding, encephalopathic, and wouldn't tolerate sedation. Extubate as early as possible after bleeding is controlled. Now, what are the drugs that can be given before endoscopy? Always start a vasoactive drug. Give a prokinetic like erythromycin 250 mg or metoclopramide 10 mg 30 to 120 minutes before endoscopy. This improves visualization. For sedation, propofol or midazolam are both safe, but propofol is preferred. In endoscopic treatment for esophageal varices, band ligation with multiband ligator is the gold standard. The vasoactive drugs should be given for 48 hours after successful hemostasis. After 5 days, start a non-selective beta blocker like carvedilol. Now coming to the management of gastric variceal bleeding. Combination of vasoactive drugs plus endoscopy therapy is recommended, though data is limited. In the endoscopic therapy, we have endoscopic cyanoacrylate injection, and it is the preferred treatment. For gastroesophageal varix type 1, treat like esophageal varices or do glue injection. EVS guided glue without coin, emerging option. For portal hypertensive gastropathy and GAVE, the first line is vasoactive agents. If bleeding is refractory, you can consider TIPS. Endoscopic options include argon plasma coagulation, RFA, or band ligation. Now coming to the role of balloon tamponade. It can provide immediate and temporary control of bleeding, but beware, once the balloon is removed, the rebleeding rate is high. It should be used only as a short-term bridge, not more than 24 hours. Otherwise, the patient is at risk of severe complications like esophageal rupture. Nowadays, guide wire assistance can help improve first pass success, ensuring proper positioning and reduce complication rates. Now, coming to the role of self-expandable metallic stents. These are actually safer and more effective than balloon tamponade for refractory variceal bleeding. SAMS acts as a bridge therapy, buying us time until we can do a definitive treatment like TIPS. It achieves immediate bleeding control in up to 90% of patients, but it's not risk-free. We may see stent migration, esophageal ulcers, or rebleeding after removal. Stents are usually kept in place for 5 to 7 days, which gives us more time than balloon tamponade to plan next steps. Now, the game changer tips. In high-risk cirrhotic patients presenting with acute variceal bleed, preemptive tips as first line can significantly improve survival. If bleeding can't be controlled despite drugs and endoscopic therapy, the best salvage option is tips. Here, an 8 mm stent is preferred over 10 mm. If a patient with acute on chronic liver failure and variceal bleed, rescue tips is also an option, provided there is no contraindication. Very early tips that's within 8 hours offers better survival compared to later tips. But we must remember certain factors predict poor outcome after tips. That is low mean arterial pressure, active spurter at endoscopy, and acute kidney injury. Tips may be futile if the patient has child poop greater than or equal to 14, MELD greater than 30, or lactate greater than 12, unless liver transplant is immediately planned. Let's talk about surgery, which is rarely the first choice today. The only indication is persistent variceal bleeding despite full medical, endoscopic, and radiological attempts. Contraindications include advanced liver dysfunction, uncorrectable coagulopathy, or hepatic encephalopathy. Interesting point, child class C alone is not an absolute contraindication to emergency surgery. In the surgery, we have surgical options like non-selective portosystemic shunts, selective shunts, devascularization procedures, liver transplantation. Which surgery to choose depends on expertise, bleeding severity, liver function, venous anatomy, and transplant candidacy. Unfortunately, there is limited comparative data between surgical and non-surgical therapies. The key determinant of survival isn't the procedure itself, it is the underlying disease status at the time of surgery. Now let's look at gastric varices. Tips. Tips remains an effective rescue therapy to control recurrent gastric or ectopic variceal bleeding. Transvenous obliterative procedures like BRTO, that's balloon occluded retrograde transvenous obliteration, or plug assisted retrograde transvenous obliteration, are also excellent options provided anatomy is suitable. Both BRTO and TIPS are effective, but BRTO has the advantage of lower bleeding rates and less hepatic encephalopathy. In some cases, combining tips with embolization of collaterals is preferred, and it reduces the chance of rebleeding further. Let's talk about infections. Patients with acute variceal bleed have a very high risk of developing infections. The usual culprits are gram-negative bacteria like E. coli. Placement of tubes like NG tubes, central venous lines, and endotracheal tubes increase infection risk. Stomach and skin colonizers gain entry. That's why these tubes should be changed regularly. Standard infection workup includes CBC, chest X-ray, urine culture, blood culture, and serum procalcitonin. The preferred antibiotic for prophylaxis is third-generation cephalosporin. That's given intravenously for 5 days. This step is strongly recommended. Now, the next is hepatic ischemia. Ischemic hepatic injury can occur in up to 10% of cirrhotic patients with acute variceal bleeding. We must anticipate and prevent it, especially in high risk groups. Now, what are the prevention strategies? The prevention strategies include early and adequate resuscitation, correction of hypovolemia, hypotension, and shock, packed RBC transfusions for blood loss, rapid endoscopic control of bleeding, and prophylactic antibiotics against sepsis. Now, what are the clinical markers of ischemia? Rise in serum bilirubin, aminotransferase, and LDH within 24 hours. This can worsen prognosis even if bleeding has been controlled. You need to monitor daily ALT, bilirubin, creatinine, LDH, and ALT LDH ratio if ischemia is suspected. Treatment, unfortunately, no specific therapy exists. N-acetylcysteine may have some benefit. More research is needed to define prevalence, severity, and therapy. Finally, acute variceal bleeding in patients with liver failure. These patients have a much higher risk of bleeding from gastroesophageal varices. Endoscopic procedures must be done with extreme caution, and in some cases, with endotracheal intubation to secure the airway. Correct coagulopathy with FFP and platelet transfusions. The role of recombinant factor 7A is still uncertain and needs more evaluation. Varices can also occur at unusual sites. These are called ectopic varices. Though rare, they can cause life-threatening bleeds. Interestingly, they are more common seen in non-cirrhotic patients. These ectopic varices can be seen in the anorectum, they can be seen in the stomach antrum, they can be seen in the duodenum, small intestine, colon, and around the stoma. Among these, bleeding is most frequent from peristomal varices. Endoscopy usually picks up most cases, but if the site is inaccessible, a radionuclide RBC scan can help locate the bleeding, which should then be confirmed with CT angiography. On endoscopy, acute bleeding is diagnosed if we see spurting blood from a varix or signs of recent bleed like white nipple sign or an overlying clot. The first line for ectopic varices, if accessible, start with pharmacotherapy plus endoscopic therapy. If it is not accessible, go for TIPS or percutaneous transhepatic variceal embolization (PTVE), provided the portal vein is patent. Duodenal varices, if not manageable by endoscopy, consider BRTO, that is balloon occluded retrograde transvenous obliteration, or even EUS guided embolization depending on vascular anatomy. Now, another section is how do you differentiate NCPH from cirrhosis? In NCPH, the liver is usually preserved. The clinical clues are no ascites, no jaundice, no hepatic encephalopathy, massive splenomegaly. These features point towards NCPH rather than cirrhosis-related portal hypertension. The good news is the mortality with acute variceal bleed in NCPH is much lower compared to cirrhosis. That's because liver function is preserved, and the first-line treatment is vasoactive drugs and endotherapy. Spatial features in NCPH, gastric varices are more common and sometimes refractory to glue injection. Coagulopathy is usually not present, so we don't need to correct iron or platelets. Antibiotics are not routinely recommended except if absolute neutrophil count is less than 1000. Rescue therapies, just like in cirrhosis, rescue options are TIPS, radiological interventions, and surgery if everything else fails. Though large RCTs are lacking, case reports and series show radiological interventions are effective. The choice of procedure depends on etiology and vascular anatomy, patient's clinical status, available expertise, and affordability. Interestingly, TIPS complications are less common in NCPH because liver function is intact. If endotherapy and radiology fail, surgery is the last resort. Portal decompressive shunts are preferred. If veins are unsuitable, then non-shunt procedures may be considered. In APASL guidelines, the pediatric group is defined as an age up to 18 years. Unlike adults, where non-variceal causes dominate, in children, most cases of upper GI bleed are variceal in origin. In the West, the main cause is cirrhosis. In the East, especially our region, the commonest cause is extrahepatic portal vein obstruction. Diagnosis and management mostly similar to adults with few key differences. Keep hemoglobin between 7 to 8 gram per dl as long as the child is stable. Higher targets may be needed in children with cyanotic heart diseases or significant hypoxia. Perform endoscopy within 12 to 24 hours is just as effective as very urgent procedures. Octreotide is safe and well studied in children, but for telifracin and somatostatin, pediatric dose and safety are not well established. Among endoscopic options, band ligation is preferred over sclerotherapy, but in younger kids with very small varices, sclerotherapy may be more feasible. When standard measures fail, radiological interventions can be used. Although we don't have randomized trials in children, case reports and series show these methods can work well. That's all for today. See you in the next video with another topic.